Another eShadowing session. It is my pleasure to introduce our physician for today, Dr. Priya Bansal. She's a doctor specializing in immunology and allergy, and today she'll be sharing with us her journey to medicine and her specialty. And without further ado, Doctor, you can start whenever you're ready.
Thanks so much for having me. I think this is a great program and a great way to learn about different specialties. And what's cool is a lot of times in med school, I find that if you don't make the opportunity, or even in residency, some places don't have an allergy immunology program. So hard. It's hard to figure out, what to do without knowing, without even having exposure to the specialty, right? So I know we're going to talk about my journey, and then as we talk about my journey, I'm going to give you a little bit more of an introduction to what I've done and kind of different ways that you can take the specialty. So I'm not going to waste more time on the introduction. I'm going to apologize in advance. I have a dog. I have a bunch of kids at the house running around. So yeah, just in case you hear anything, apologies in advance. So for me, everyone's got their own reasons, right? As to why did you go into medicine? Why, and sometimes we're torn, it's like, well, I like this and I like this, or should I do a PA, or should I go into medical school, or do I want to go into business, or do I want to go healthcare consulting? For me personally, I was more sick as a child. So that was what it was. I had exposure to the hospital system when I was younger. I was getting hospitalized like several times a year, and I really felt like I could make a difference, and I wanted to help someone. And I felt, a connection to medicine. So that's the main reason for me as to why I went into medicine. There's lots of different pathways that you may have heard of. So some people go right outside of high school. Some people go after going to college. For myself, I went to it's a BSMD program. It was with Penn State Jefferson Medical College. And so at that time, what I did is I applied right after high school. So I applied, I would say, and it was like a 6-year program at that point. So went to the BSMD program and then went on to Jefferson Medical School. At that point, I had some personal and family issues. And so I actually had to transfer medical schools. So my a final degree was University of Illinois, Chicago. Like the traditional journey that we hear of is, more so 4 years of college. I know some people do 3 to 5 or 6, and then go on and take the MCAT and then apply to medical school. If you do a straight medical program, like the way that I did, I think it just kind of depends on, what you envision, right? And some of the programs are more strict than others. Like ours was at that point in time, like, I don't know if it's changed, but at that point in time, it was, you had to maintain a 3.5 every semester, a 3.5 overall. You had to be in, like, I can't remember, if it's 87th, I think, for your MCATs percentile for MCATs. So what's interesting is when I had talked with my husband, he at that time was saying, he said, it's so interesting because like all of the requirements that you maintain, it was like you had to do that to get into medical school anyways. So I think with, even if you're doing some of the direct programs, they're more strict. Some of them don't require the MCAT. This program in particular, like I said, mine was 6 years. It since then has gone on to be a 7-year program. So that's kind of the story with that. In terms of residency and fellowship, so in order to go into allergy and immunology, you have to have at least 3 years of internal medicine or 3 years of pediatrics. So you don't necessarily have to do both. There are certain fellowship programs that combine both the medicine and the pediatric fellows. There's other allergy programs that are geared, that call themselves pediatric allergy, and there's other ones that call themselves internal medicine allergy. So a great example is here in Chicago. I'm from Chicago. So I did first I did internal medicine and pediatrics. So I boarded in both. So I did, which, that was a combined program as well. So that was for 4 years. However, if you did the straight internal medicine track, that's 3 years. You do straight pediatrics, that's 3 years. And like I said, this combo program for me was 4 years. Went on then to go into Rush University Medical Center, and I did my fellowship in allergy and immunology there. So I think what's interesting is that like I said, each different location you have is going to have a different perspective. So for me, Rush was a combination. They didn't say you had to have medicine or pediatrics, but even if you look at our city and you look at Northwestern has a pediatric allergy fellowship track and they have an internal medicine. However, when you graduate, whether you went on the internal medicine track or the pediatric track, when you finish your fellowship, you do have to take your boards, and the boards, you have to be able to answer questions for both. So even if you go on one track, it's not like to get board certified, you're going to have a pediatric allergy immunology exam. Your board exams for your subspecialty are going to include both adult and pediatric patients. Now, when you get out after that, you can choose to practice only one or the other. There are some physicians that only do pediatric allergy or adult allergy. Majority of allergists see both. Now, their percentages can be different based on their training. I had met with one of my good friends just the other day, and she has about 60% pediatric and 40% internal medicine. She trained in pediatrics. So, and then, like I said, somebody trained in internal medicine, those percentages might flip. So in allergy, a lot of people see both, but if you really wanted to, you could probably find an area where you could do one or the other or specialize in one or the other. So this is what we talked about. You have 3 years of internal medicine residency or 3 years of pediatrics residency, or you do what I did, the internal medicine pediatric combination residency. What is allergy and immunology specifically? So allergy and immunology, I mean, obviously we've heard more about allergists and more about immunology this year, I think, than any other year in the news. And that's mainly with COVID-19, because you hear all this talk about antibodies and like, are we immune to COVID-19, and how do we find out about vaccination and who's immune? So this has been very readily in the news. Bread and butter allergy immunology is more allergic rhinitis. So like itchy, watery, and allergic conjunctivitis. So conjunctivitis is the itchy, watery eyes. Rhinitis is the runny nose, sneezing, itchy nose, symptoms like that. Asthma, atopic dermatitis, which is more related to eczema, and again, affecting people of all ages, and food allergy. And most allergists treat a combination of all of these. There are some allergists lately with, there has been a huge uptick for allergists to do what's called OIT, which is oral immunotherapy, where they treat you to a particular food allergen. So let's say that you're allergic to peanuts. They're trying to desensitize you to a particular food, such as those peanuts. And it's almost like doing allergy shots, but I'm taking the peanuts orally. And there are some allergists that specifically specialize in oral immunotherapy, and that is their passion, and that's what they do. So maybe they're going to focus on that. My practice is more chronic disease, and more complex. So I see conditions called hereditary angioedema. I take care of patients with immune deficiency. I take care of patients that are on biologics or have severe disease. So what does this mean? So hereditary angioedema is a disease where you swell. So, and the swelling comes because you have a deficiency in or a dysfunctional C1 inhibitor protein. So basically this causes your hand to swell, your throat can swell, your lips can swell, your stomach can swell. So it's not anaphylaxis because it comes up, it lasts 3 to 5 days without medication, and it goes away. Now there's medications to treat it. Immune deficiency is treating some of those children and adults who get sick over and over for whatever reason, and their immune system can't mount a response. And there's various defects that are there that you work to treat. The biologics are used for severe disease. So in terms of Let's say that someone's eczema or atopic dermatitis is severe. We've tried them on steroids, they're using high dose topical therapies, it's damaging their skin. Or let's say that they've had 2 surgeries for nasal polyps and the polyps are totally blocking off the nose and they keep coming back over and over again. Maybe we need to use a biologic or an injection therapy for that. There's also severe disease like asthma, where I have given patients who are on high dose steroids or on multiple inhalers and using their rescue albuterol way too often. And we use biologics for that. We also use it for really bad hives. So let's say that somebody is breaking out with these big bumps, kind of look like mosquito bites hives. And I'm treating them to the max therapy, which usually is twice a day antihistamines, H1 and H2, which means something like Pepcid, as well as your traditional allergy medicines like Zyrtec or Xyzal. And no matter what I'm giving them, they're not having enough relief or they might need steroids. They also qualify for this therapy. So my practice personally is probably seeing some of the bread and butter and then also doing the more complicated visits. We have certain procedures in our specialty, and I think these are the procedures that make our specialty unique. We have allergy testing. Some of you may have had testing. Others, if you haven't had testing, this is what somebody really looks like when they're really allergic. So to do this, what we do is we take a plastic piece. There's several different brands, and not surprisingly, all these brands have been tested to find out which one's the most accurate. Testing is either done on the back or it's done on the forearm. Where we use the plastic piece, we dip it in some of the antigen and superficially poke the skin. So there's no needles at this level of testing. So this is just a plastic piece. That's all we use. And then different offices do it differently. Like when I was in training, we used to use a ruler and we would mark the actual size. And I know a lot of offices that still do that. I now rate them 1, 2, 3, and 4, just so patients understand them more. 4 is severe, 3 high, 2 medium, 1 mild. And that way the patient can understand what I'm talking about. Most allergist panels, I would say, range from, 30 up to usually 80 at the most, prick skin testing. It usually swells up like a hive. And if you're allergic to something, you're going to be itchy, kind of like, I don't know, in these bottom spots, if you can see on the bottom right, those big welts that are really swelling, we would call that a 4 because it's spreading out from its center, and definitely an allergy to that. I'm going to go back here one more on allergy testing. We also do, let's say that you come out negative to this, or I'm kind of convinced you have a convincing history to me that you have a dust mite allergy and I want to check it out further because you're not popping to dust mite. We do intradermals, which is using a needle to superficially poke the top of the skin barrier. We put it right under the skin. We put very minimal extract. It's 0.02. And we inject it in the top and then give it 15 minutes to see, do you react to that, using an intradermal. We don't start with the intradermals because some people have pretty bad reactions, like this person did, even just with the superficial prick. So those are like the 2 steps to allergy testing that are out there. We also do spirometry. So spirometry is a breathing test. So what we're doing is we have somebody with a machine and we have them look at this screen and we say, blow, 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 blow. So what we're looking is, what are you exhaling in that first second? How does your exhalation go along? And then we look at the inspiratory, the inhale from that. And we try to figure out, okay, is this consistent with asthma? Is this consistent with some other kind of restrictive lung disease or problem? Is this a problem with vocal cords? So we're able to kind of gauge what issues they're having based on spirometry. Spirometry has been kind of difficult right now with COVID-19, only because we were worried that if people cough, they're going to expel particles all over the room. So some people have designed negative pressure rooms. Some people have not done spirometry. Other people have done it outdoors. I know it's starting to come back now because people are starting to do it for people that have been vaccinated. or they've done a COVID test prior to them coming in and then had them do their spirometry. So this was on hold, and you may not have heard of it or seen it during the pandemic, but now it's starting to come back. Patch testing looks at chemical allergies. So what we're looking at is, is it a particular wood alcohol, or is it like a lanolin? Is it a paraben? Is it like your dye that you're allergic to? So this is traditionally a patient who is coming in with a skin rash. Generally comes about 48 to 72 hours after exposure. That's why we put these patches on your back. We leave them on your back for at least 48 hours, and then we read them at various times. Now, sometimes people do a 48, a 72, a 96-hour reading, but basically looking, are you reacting to any one of these chemicals? Because that's important, that we want to help figure out and diagnose, are you allergic to a particular chemical? Because then if you stop using it, hopefully that rash will clear. This is what I was talking about before with the biologic injection therapy. So we also do this in the office. There's various forms to do this. Some of these therapies are given at home. So just like this patient, we would teach the patient to do it themselves. They could do it in the fat tissue in their abdomen. They can use the fat tissue in the bottom part of their arm. They can also, and they can also use their thighs. Most patients usually, if they're injecting themselves, will use their stomach. If we inject them in the office, we traditionally use their arms. There's different forms that offices do this in. Sometimes the office buys the drug themselves, then injects it for you. That's called a buy and bill practice. Sometimes the office gets it from a particular pharmacy, a specialty pharmacy. So they get it and then they administer it for you. And then the other option, like I said, some of these drugs are allowed to be done at home. So there's several different options that are there. Also, many people may have heard of allergy shots. So allergy shots, which this syringe is actually a little much. Most of us administer 0.05 or less in volume. But the allergy immunotherapy is us tricking your body to tolerate what you're allergic to. I do tell people, for the most part, that in most offices, allergy immunotherapy is once a week for 6 months to a year, and then it's once a month for 3 to 5 years. So I tell people, I say, you're married to the office, and don't enter the marriage without being committed. So you definitely want somebody to know upfront that they have to be committed. When we do immunotherapy, we're hoping that, I tell people I start you on shots and medicine, and then as you get better, I take the medicine away, and then eventually I take the shots away. So the goal would be hopefully to buy you 10 to 20 years where you feel pretty good and you're not experiencing allergy symptoms. There are other ways to do allergy immunotherapy other than shots. There are sublingual drops. Now, most allergists don't use drops. Some of them do, only because they're not FDA approved. And so the Academy hasn't supported the use of drops. So a lot of allergists don't do that. You're going to see more drops in an ENT office, or maybe chiropractor or somebody else, because like I said, allergists do not use drops for that reason. The drops are assumed to be less effective than the allergy shots, but sometimes people find that it's easier to do at home, and they're willing to put up with that it's less effective if they don't have to come into the office. And then lastly, the other type of immunotherapy that's out there is there's tablets that are standardized. So we have grass. In the US, what's approved is grass, ragweed, and dust mite tablet. So some people, let's say that your predominant allergen is dust mite, and that's the big thing that bothers you, even though you have other allergies. You can take a tablet yourself every day at home, again, for those 4 years. Most people say 3 to 5 years, but most on average do 4 years in order to desensitize yourself to that particular allergen. It's not usually, for most people, not a forever solution, but like I said, it does buy you, for most people, 10 to 20 years. So these are kind of the main therapies that we have and procedures that we have as allergists. So you can see a majority of our procedures are outpatient. The one therapy that's back here where we talked about procedures of skin testing. So the skin testing can be done for both food and not for intradermal, but usually for prick skin testing. The other one that I didn't mention, which is a big push right now, is drug allergy testing. So we just countless numbers of people get incorrectly labeled with penicillin allergy, and penicillin allergy can be outgrown in 10 years. So I use myself as an example. I had anaphylaxis to penicillin when I was a teenager, and I have tested myself and subsequently taken penicillin, and I'm fine. So I tell people, even if your throat's closed before, you can still get tested for penicillin allergy and confirm that you don't have it, because we definitely want to get this off of people's labels. So what this involves is doing the skin test, like this prick skin test, doing the intradermal under the skin. And then the last procedure, actually, that I didn't put a slide up because it's kind of hard to say, is like that oral challenge. So basically what we do is let's say the skin test is negative, we go ahead and give you the penicillin in the office to make sure that you do okay. These oral challenges we also do with foods. So let's say that I suspect that, or somebody gives me a history that they had a severe reaction when they were age 2. And I check either, maybe I might start with a skin test and do a lab test, or I might just go straight to the lab test to look at, because right now you can map out particular components to find out how bad an allergy is. And I say, this looks like I can challenge them, like I can see what happens. So I can go ahead and bring them in and challenge them in the office to that particular food. And generally we do this over several hours in the clinic, and we watch them and monitor them and make sure that it goes okay. So that's probably our one of our other procedures that ties in with allergy testing. So speaking of the peanut allergy, I wanted to go on and do a few cases. And so we've got a 3-year-old who has a history of peanut allergy. They're presenting with a rash around the mouth, and with exposure to peanut, and this was, again, like very young, at 6 months of age. And the parents are nervous, and they've avoided peanuts since then. The mom does have a history of allergies. She has seasonal allergies. She has no surgeries, no known drug allergies. Her review of systems, where we're reviewing all of her pre-existing medical conditions, it's unremarkable, except she does, except the 3-year-old does have occasional seasonal allergies. So what would we do for this particular child? So if we did prick skin testing, we could, again, look at the seasonal symptoms. We might even do, prick testing, or like I said, some might favor doing a particular blood test to look at it. Now this one, because there wasn't any history of throat closing, trouble breathing, trouble swallowing, we went ahead and did the peanut skin test. The peanut skin test is negative. The tree pollen is positive, which is kind of what's expected for what mom and dad, have described. The immunocap test is done, and it's showing mild positive RAH8. What does that mean? I tell people, like, your hand's got 5 fingers. Peanut has multiple different parts to the protein. So there's particular proteins that are more linked with anaphylaxis. RAH8 is more linked with more milder, more abdominal symptoms, not really necessarily a child that's going to go through anaphylaxis. So if, at this point, then we would say, it looks pretty good. I think we should try to do an oral food, and I'm going to go back here, an oral food challenge. So what else would we do? So what we would do then is we would bring them back. Different offices do it differently. Like some offices say, bring in raw peanuts. Other ones will have you bring in peanut flour. Other ones will have you bring in peanut butter. Other ones will say, just bring me something, because they're 3. We don't know what they're going to eat. As long as they've had the other ingredients on the label, bring that into me and we'll test and challenge. For me, I usually do my challenges as the first patient. I tell them they're going to be there most of the day. That covers in case there's a reaction. And like I said, we give them a little bit at a time, and watch them and make sure that they do okay. And for many patients, it's been life-changing, because if you are, you've been told you're allergic this whole time. And if we all of a sudden are able to get that label off, that's a huge thing. And even if there is a reaction that starts, we're able to treat it right away. But then again, the parents know, like they're at a place where they know what's going to happen. And I think that provides a lot of security for the family. The other thing that you would do with this patient is you would counsel them on tree allergy. So tree pollen, traditionally it comes in different waves. This year's tree pollen season has been particularly brutal because the couple of freezes we had up here in Illinois. But what we do is we usually talk about, hey, tree pollen's going to come out mid-March and it's going to go all the way usually through mid-May. But I do tell people to watch the pollen counts. We tell them if they're outside, playing outside, you want to make sure that when you come in, you wash the pollen off of you. Like, don't let the child sleep in the pollen. The other thing is not to open the bedroom windows, because once again, you're bringing all of the pollen back into the bedroom. So I think that's kind of like the really important counseling that we want to do for this patient. Now, if the mom or dad feels that the allergy is getting bad enough that they feel like the spring allergy needs symptoms, there's several medications that have gone over the counter that, depending on what we saw on exam, like let's say there was some nasal stuffiness on exam, we could either do a steroid nasal spray like fluticasone or Flonase or Rhinocort, which is budesonide, or there's Flonase Sensimus. There's several of them that are over the counter where you could do one spray per nostril daily at that age. Or you could also take an antihistamine. And again, once again, at age 3, you would dose appropriately for a 3-year-old and then use that for the allergy as needed. Now, if the mom or dad say it's not every day, then like I said, the medication would be as needed. If it's a consistent problem in the allergy season, I would probably say to do it consistently. Most of the time for allergies, what I advocate is prevention, because preventative medicine goes so much further. Why I tell parents, why do I want to treat you? I want to treat you so that not just that you feel better, like that's wonderful, but I want to prevent problems in the future. So if the nose is constantly stuffy, you could develop hypertrophy of the adenoids and then need surgery to get your adenoids out. So as much as we can do preventatively, that's what we want to do. So again, those guidances for taking a shower and keeping the windows closed and using the medication, it's all to help prevent future problems. But again, if you don't see regular symptoms, we don't want to over-medicate either. So that's kind of a discussion to have with the patient themselves. So our next case is a 25-year-old patient who has a history of recurrent swelling episodes. So this patient is like what I had talked about before with the hereditary angioedema. It's a young man who has a history of hand and foot swelling. It comes on at less than 3 days and it lasts through 5 days later. Nothing really helps his symptoms. He's gone to the emergency room. He's received epinephrine. He's been given antihistamines. Nothing he does makes it better. He does know that when he gets sick or an illness, it's worse. When he's gone skiing, it's worse. And sometimes when he's really stressed out, it tends to come out. So some labs are done. It's a baseline C1 inhibitor, functional inhibitor, and a C4. And what we found is that the C4 is low and the C1 inhibitor is low. So this for us clinches the diagnosis of hereditary angioedema type 1. The good news is that there is multiple medications out now where years ago there really wasn't. Years ago, there was only plasma, like fresh frozen plasma, which you'd have to give to replace it. But now there is quite a few medications, and there's actually C1 inhibitor that you can infuse, as well as some other mechanisms to help in the cascade that actually prevent the problem. So with this particular patient, there was a grandmother with a history that was never evaluated. Again, this is kind of what makes it hereditary. Now, let's say that you didn't have the grandmother. Even him himself having those labs would make the diagnosis of hereditary angioedema, because you could have a spontaneous mutation, and that's possible. So he was, diagnosed, and it was dependent on his frequency of attacks. And we looked at his proximity of medical care, and we started him on prophylactic medication. So let's say that you live far away. That makes a difference, right? If we have no access to medical care, we can get into a problem situation. There is a pretty significant chance, like 50%, that you are going to get a laryngeal attack at some point in your life. So if your throat swells up and you're far away from medical care, that's a big deal. So sometimes we have to look at different things for different patients as to what makes a difference. So I had one patient that was almost exactly like this, that lived very close to medical care, and he did not want to take anything regularly. So all we had to do was give him medication that he could use in an emergency, kind of like when you have a patient with asthma, they have an inhaler that they take regularly, but they have an emergency inhaler. This is the same concept. So you can have a medicine you take regularly, or you can have an emergency medication, or you can have both. So this particular patient did both, only because of the proximity to medical care. So we want to look at quality of life, frequency of attacks, closeness to care. Have they had a laryngeal attack before? Because that makes it even more serious. So there's certain factors that we're going to look at. So they're started on C1 inhibitor regularly, and they've been given a rescue medication to hold. This is kind of a picture of what it looks like with somebody hereditary angioedema. So you could see on the left here, this is what the patient looks like normally. And then you can see the progression as she goes through a few hours later, that by the end of the attack, again, without treating it, you can see the severe lip and facial swelling when she had this particular episode. So it is pretty remarkable. And if somebody comes in looking like that, you're thinking, oh my gosh, is it anaphylaxis? And we definitely don't want to treat them with the wrong medicine. Like, it's very important that they get the right medication for this condition. So the other things that I've had a bunch of consults for lately is COVID-19. So a patient will come in and tell me, I have a peanut allergy and I have asthma. Can I get a COVID-19 vaccine? I had COVID-19 a couple of months ago. I still can't breathe. What do I do? I had COVID-19 6 months ago. I can't smell or taste. What do I do? So going back to our first question, I have peanut allergy and asthma. So with COVID-19, we've been divided into 3 separate categories in terms of allergies. So we have a green zone, or yellow zone, and a red zone. The green zone is, I've had environmental allergy, I've had a venom allergy, I've had food allergy, I could have had a drug allergy. It's still considered to be okay to give the COVID-19 vaccine, and they just have to have a 15-minute observation. The yellow zone, when you step into that, it's patients that have had anaphylaxis to an injectable medication. So let's say that I was given or if we look back at my old case, anaphylaxis to injectable penicillin. If that was active, then again, that would be more worrisome, because then you might want to be observed for 30 minutes instead of 15 minutes. And maybe you might want to give that patient some epinephrine, or do the vaccine in a more secure setting. And then the last category is your red zone. Those are patients that have had anaphylaxis to the vaccine, or anaphylaxis to one of the parts of the vaccine. Those are the patients where you really want to reevaluate and say, okay, can we do a different type of a vaccine than maybe the polyethylene glycol vaccines, which is the Moderna, Pfizer? Could I do the J&J maybe safely? So in general, we are not restricting for asthma or peanut allergy. We are saying go ahead and get the vaccine. These patients that are coming in with a couple of months ago can't breathe, we're working with them. We are doing chest x-rays. We do sometimes if it's necessary, a CT scan with a follow-up CT scan. Sometimes we're using a topical inhaled steroid to see if that helps to calm down the inflammation. But with COVID-19, there's a lot of new things that we're learning every day and kind of working with that with the breathing. In terms of the smell and taste, they have done some studies where they're starting to use nasal steroids, which are, like I said, quite a few are available over the counter. They have also started to do some smell therapy using different smells to try to re-trigger the olfactory system, to start kicking in and to be able to smell some of these things again. But these are very real situations. There was a time where I was seeing probably 20 plus COVID a day. Majority, I would say for me, was on telemed because I would screen them. The reason you're going to see them as an allergist, you're like, wait, you're not the ER. Why are you seeing COVID-19? The reason you're seeing them is a lot of people think things are allergies, right? So they're coming in with a stuffy nose or a runny nose or a sore throat or a cough or shortness of breath, and they think it might be asthma or allergies, and it ends up not being asthma or allergies. It ended up being COVID-19. So once again, you are going to see this particular subset of patients, which is why, again, I was pretty involved with the COVID-19 task force as well. So my advice for pre-meds is to find good role models and mentors. I don't think that there's anything more valuable than that, because you're definitely going to get the people on the other side, right? There's going to be people that are going to try to bring you down. And that's just, unfortunately, it's in some of the places very cutthroat. So, there's people that they'll say like, well, I went through it, so you should, I suffered, so you should have to suffer. Or they just want to bring you down for whatever reason. So you have to try to tune out the noise, fight the fights that you need to fight, but really find those good role models and good people that can be in your life. The other thing I hear a lot about is I'll hear some pre-meds tell me, oh, I want to go into X. My advice for that would be try not to commit to one area too early. Try to keep an open mind because it'll let you enjoy your rotations a lot more. It's good to have an idea. Like I was pretty sure I wanted to do dermatology. I did 2 years of research in derm. And then I did my rotation and hated it. And then I switched gears at the last minute to do allergy. But and that's going to happen sometimes. Like, let's say you thought you were going to love something and you just didn't love it. And that's perfectly fine. It's perfectly fine to pivot and switch and do what you want to do. Try to think about what you want your lifestyle to be. And I know at the beginning, I was more fussy in terms of I was like, oh my goodness, I don't want, I don't want anybody to tell me about lifestyle. I want to work hard and I'm going to be this and I'm going to be that. But you do want to see where you ultimately want to end up. Do you want to practice in the clinic? Are you somebody that likes the hospital more? Do you like being coming in and delivering that baby at the last minute? Or do you want something where you have more control of your hours? Would you rather be the one that's the first to arrive to treat the trauma or be in the ICU? So these are all personality traits that you have to figure out for yourself, like what you want to do. Try to stay organized, because organization is going to help. If you're very disorganized, it's very hard to get through med school. It's, really knowing what your deadlines are, what to prioritize, what not to prioritize. That's extremely important. To stay involved with. And knowing that everybody around you is smart, right? So they couldn't get into medical school unless they were intelligent. And I tell people the common joke for a physician is, what do you call the person at the bottom of the med school class? Doctor. Right? They're still doctor. It doesn't matter. So even if you graduate, you're going to be a doctor no matter what. So remember that even the person at the bottom was a really smart person. They got in. So there are going to be times where maybe life like even outside of medical school, it's going to throw you a curveball or you have a problem. The main thing to remember is that if you need a hand, reach out. There are definitely people there that are willing to help you, again, it's about having that positive role model, somebody to help you when you need it. I would advise to try to talk to as many people as possible. You want to talk about your training program, your future profession. So I think sometimes people, they go to their interview and they're so nervous about fellowship and or residency. I mean, you kind of don't take in like the forest around you, like get so caught up in the trees. So definitely you want to try to talk to as many people as possible about your training program and your future profession as possible. You also want to try to make time for yourself to decompress. So whether that be doing a particular class or taking like even like 5 minutes, be like, I'm going to take a step away, because like I said, there's going to be times that it's very intense. So those would be kind of like my big pearls. I want to talk about one more thing before I go to questions. I want to share a little bit more about kind of, now that we've seen this whole presentation, about what I particularly did. So just so you know what possibilities are out there. So I ended up, after I went on and I did private practice. And then after I did private practice, I went on to go ahead and lately, I would say about 6-7 years into private practice, I noticed that I was starting to get more burnt out. And after that burnout set on, I really thought, I'm like, I have to do something else. So I started volunteering for our national association. After I started volunteering for that, I kind of got more of a sense of purpose because I was doing more advocacy. And then I started doing consulting. And so I did some pharmaceutical consulting. And so now I do quite a bit of things. So I do, after I worked at a particular private practice for 15 years, I broke off. I actually started my own practice about 2 years ago. And then I also have been doing a lot of things on the side. So I have the private practice, but I still do the pharmaceutical consulting. I consult with businesses about their COVID-19 practices. I do, like I said, I am on the COVID-19 task force for our academy. I do a leadership task force. I do a communications oversight task force. I work on racial disparities. I've written different papers. I love academics still. So I've written different papers on telemedicine, physician wellness, asthma, and social media. I've done, I also have done spots with the media. I've done spots in the news. And I do advocacy with like senators and representatives. So for me, I like being busy, and I like using my brain in different ways. And I can say, like, I had done like 4 different talks last week where I did, one day I was doing a CME talk. The other day I was doing teaching other members of the college like how to use social media for advocacy. So I would say I divide my time probably 70 like volunteer work, and I try to do probably like 30% where I do paid work, but that's what keeps me happy and keeps me ticking. And I think the point being is that with medicine, you could do anything. Like if I decided I wanted to, with my experience, to work for the pharmaceutical industry full time, I could do that. If I wanted to use my degree, and there's another doctor association where they post up jobs. If I decided I wanted to leave this and I wanted to be a financial analyst, I could go and do that. I could continue doing what I'm doing. So there's so many options. And that's what I love about it is, please, like, never feel like you're stuck in one thing, because I don't think you are stuck. I think there's, where one door closes, another opens. So that's what I love about medicine, and it's definitely what I love about allergy, because I think there's so many, it's such a broad field that there's so many different ways that you can take it and customize it to make it work for you. So that was the main topics that I wanted to convey. And I'm so excited to speak to all of you and answer your questions. So thank you so much.
Thank you, Dr. Priya. Thank you so much for your informative presentation. At this point, if anyone has any questions, feel free to drop it in the chat box. I have a question. You said that you were in the COVID task force, and I was wondering how it was like working with the first wave of COVID patients when COVID was very new?
Yeah, I like basically it was scary. I'm not gonna lie. I mean, it was scary. I was doing everything that everyone else was probably doing. Like basically you were so scared because we didn't know if it was contact, we didn't know if it was airborne. What we would do is we would like I'd go to work, we'd have our face shield, like I wore the N95 the whole day long, kind of like dressing in clothes that you could basically throw, right? So you were changing in the garage and trying not to, because again at the beginning we didn't know anything, so you're changing in the garage trying to not infect your family. I was staying very far away. I don't even think I didn't hug my parents actually till March of this year, which was really sad because my parents live right here. But I really did not want to infect them until I knew that they, had been vaccinated, just because I do see COVID, and I didn't want to take any chance to get them sick. So I think, so definitely, I think it was extremely stressful, and we realized that how difficult it was to deal with a pandemic without fully being, prepared to deal with a pandemic. The one thing I do have to say is the community stepped up quite a bit for me. And that's what I mean by like people reach out. Like you'd be surprised like how awesome people are, because we had patients that made me, that's a face shield I still use today. Like one of my patients 3D printed me face shields, and it was amazing. I had patients drop off masks because we had no access to masks. I had patients, send us food, to thank us, like at least to be able to help us get through the times. We had, I think, different patients send us gloves. So, like there were people that were helping in the community to tie us over, and get us through the pandemic. And the other big issue is like, so I still kept the clinic open. We still saw my biologic and my immunotherapy patients to get their injections and come in, come out. What we did is we used to allow patients to come in whenever they wanted for their allergy shot. We started scheduling them, to create social distancing. And then the other thing that we did is you went from 0 to 100. Like, we skipped 10 years with telemedicine, and boom, it's like, okay, I can't see patients. I have to see these patients. How are we going to make it happen? The next day I had a telemedicine platform. So I think, again, this is all about learning how to pivot, how to deal with it, and like think on your feet and find solutions, because that's what all of us were doing, and leaning on our friends to look at what solutions did they have and what can we use and what can we offer them.
Thank you for sharing.
Thanks.
Yeah, it's really nice to hear the community work.
Yeah. Oh my gosh. That was incredible.
We have a question from Yuna. She says, would you recommend immunology for people who don't like working with blood?
It's kind of tricky, like in terms of like, how much do I don't think I really work with blood. I mean, definitely in residency, but it also depends where you did it. Like, so, where I purposely chose to do my residency at USC because I wanted to like really get up on my clinical skills. So I could probably start an IV in a scalp and a foot. Like I can start an IV anywhere on you. So I have no qualms in drawing blood. And I did a lot of my own blood draws. I even still do some blood draws. But at the moment I have a phlebotomist, but prior to having the phlebotomist, I would just do it myself. So I don't think you necessarily have to draw blood if you're in immunology, but there's a lot of fields where I don't think, quite a few of the fields, I don't think you would have to be drawing blood or be seeing too much blood. Again, it's going to be more in training where you're kind of made to do some of these things just to get your skills up. But then after that, I don't think so. So immunology would be a good, I would think, yeah, you'd be able to be fine and not have to see blood really.
Thank you. And I have another question. What other specialty would you pick if you could instead of immunology and allergy?
Ooh, gosh, that's a hard one. I would say I loved I I loved a few things. So I loved ICU. Like I absolutely loved ICU. I think the biggest one was that I didn't like the instability of the hours, but now with the hospitalist type system, I think they have more shift work, and I think I would have been okay with that. But I like the codes. I like to be able to save people, and so I enjoyed that. I also enjoyed ENT, like ENT surgeon. Like I liked surgery, and again, that's sticking with the upper airways, so I enjoyed that. I think my derm experience was just my rotation wasn't that great, but again, because I did 6 years and then I skipped a grade early on, so I was like early 20s when I graduated med school. I think I was like 22 or 23. I don't know, something really young when I graduated med school. And so it was weird because, like I just I didn't have the common sense, I think, at that time to realize, okay, this is a bad rotation. So I may have gone back and done derm, but I would say those three fields I like the most.
Okay, thank you. There's another question from Jasmine. She says, how do you deal with burnout and imposter syndrome in medicine?
I mean, I think that the burnout is difficult, right? Because, and like I said, this one is probably one of my babies because I did write a paper on like combating burnout during COVID-19. And for me, it's the burnout part is about finding like your Zen place. Like it's about finding your like what works for you, right? So for me, the burnout is more like I would say for me it's playing tennis was a way to combat burnout. Like I love exercise, so for me that helps me. For me, having purpose helps me. So in terms of like the 7 years when I started to get burnout, it was because I felt like I was doing the same thing and I didn't have purpose. And for myself, I felt like I have to recreate myself over and over and over. So for me, it was part of that recreation that like really, really made a difference for me. Like I thought that like I thought that, it was just, I was just getting so like frustrated, like I can't do the same thing. So for me, I think that when I did it, it was like, okay, these associations kept me busy for a while. And then afterwards, I was like, ooh, consulting. I've never done that. Let me try that. And then after I did the consulting, then it was like, oh, I've never done like the national news. Let me like, they asked me to do the national news. I'm like, okay, cool. I'll do the news. And then this last year, I hadn't done a lot of papers in the past. And then this year with COVID-19, there was the opportunity to collaborate and write some of these papers. And then I got into that. So for me, I deal with burnout by recreating myself, like not stagnating in my profession. And I've always been something that likes the newest, the latest, the greatest, like, and not getting stuck in the status quo. Like even like I meet with like some of the MSLs, which are medical science liaisons, on a pretty regular basis to learn like what is the newest and the greatest and what's coming out and what's in the pipeline, because I like to keep abreast of new information. And so for me, that's the biggest thing. And then, I was like starting to look up imposter syndrome because I was like, I'm not sure in terms of like what part of the imposter syndrome are you for Jasmine, like, is she more referring to just self-doubt? Like you feel like you're an imposter? I'm hoping that that's it. Yeah. Okay. So basically, I keep up with that by keeping current. Like I actually probably don't have feelings of imposter syndrome, like I don't think there's times where I've doubted myself and doubted my skill. But again, I think that's just being a good doctor. Like if you don't know what you're doing, you reach out, like you have to know what your limits are. And I think that's really important to know. So for example, I used to do a lot of oral immunotherapy. I got frustrated because my teens started throwing, like as my kids aged out, they would throw their peanuts under their bed and they wouldn't take their daily dose. And I got frustrated because they weren't doing it. So then what I did was I decided I'm not going to do OIT as much. Like I do a little bit, but I have a girlfriend who does a lot of it. So I know that I don't want to do it, but I have a connection that's going to do it. So I think if you doubt your skills, then it's more trying to keep up and learn information, or reaching out to people who might know more than you and tapping into them. Because I have no problem saying, hey, I don't know how to do this. What do you think? What do you, what about this? Because you have to know what your limits are. So that's how I deal with that.
Well, thank you, Dr. Priya, for all your time and your contribution.
Yeah, no.
And is there a way that people can reach you through email?
Yeah, sure. I can put it into the chat if you'd like.
Thank you so much. And just in case if people have more questions.
And that's my like personal one. So yeah, just yeah, like if you want to keep it in that one. And hopefully that'll help you guys, because and I would be more than happy to help anyone. Like, if you have any questions, or you're like, hey, I'm stuck and I don't know which way to go, obviously not going to make the decision for you, but at least can give you some tips on both sides of the coin.
Thank you so much again, Dr. Priya.
Thank you.
Thank you. And for those of you who are currently attending, we have posted a Google form link in the chat, so make sure to verify your attendance. We will be handing out our certificates at the end of spring semester with your total hours. And thank you all for participating.
Have a good night.
You as well. Thank you again.